So, I think we all know where we are, and the question is, how do we incorporate EMS in the broader healthcare reform debate? And one of the things that we keep hearing as we're thinking around this table is EMS is responsible for 1% of the direct expenditure for Medicare. And we talk about dollars with Medicare, they don't care. That's not that big a deal. But when we think about the downstream cost from EMS, it becomes a little more significant. But I want to emphasize we are in the healthcare reform debate, but our thought earlier has been we are not here primarily to save money, because everybody else is trying to come to CMS and tell them they're going to save money. We are here to really do better care for the individual, better care for the community, and oh, by the way, it probably will save money. But we're not leading with that. We're trying to get there. I think we all know we hopefully do emergencies well. The joke that we had at the first meeting is, I don't know why they call the fire department anymore, because they really don't put out fires. Why do they call us emergency medical services? Because we really don't respond to emergencies. We do, but it's rare. We more commonly encounter other types of medical care, and that's really what led us off on the discussion. So we know the landscape has changed. The good news is that we don't have to have a vote here today, so we don't care which side of the political aisle you're on, that we're going to move along. This is kind of the current state, and I have to give Beeson credit for this slide. This is true. It is completely chaotic. We respond in the middle of what may be an otherwise very well-developed health plan for an individual, and the 911 button becomes the escape arm. It becomes the, okay, fine, I've got a medical home, I've got an ACO, I've got all the rest, but I'm tired of waiting on that 911, now I'm out. And I get to go and spend money and do things in a different place and have uncoordinated care. And the goal, I think, of what we're trying to get to is that we will be integrated with all of those other healthcare plans rather than be a separate silo. I believe that's really kind of the talk. We have to talk about the dollars because this is reality. My father gave more money to Jesse Helms than I want to let you know. The beauty is my mom gave an equal amount to ACLU, so it balanced out. But it is a dichotomy of our world in that my father hates the federal government, but loves his Medicare. Well, Medicare is the federal government when you look at the way the spending line is going. So we have to work in that, and it may have to operate more like a business. So this is the part we think we have some place to impact. Between 5 and 10% of the population, and in my community every year, 7 to 8% of the population contacts 911 via EMS. So this is not a fringe issue. A large portion of the population contacts us every year. Depending on which literature you review, between 11 and 52% of those patients could go to the hospital some other way, or indeed go to a clinic or go somewhere else. They do not require that. This you call, we haul, that's all thing is probably got to change, or at least we think it's got to change. And if you look at who is calling EMS, the emergencies are not increasing. The general medicals are increasing. The other general illness, the psychiatric calls, those are going up. Not we've been shot, stabbed, or having a heart attack. If you haven't seen this from February's JAMA, this describes the financial plan very well. And so I think we don't have to delve too deep into the financial question because it's been very well described for us already. We speak of the triple aim, and if you think about what we're going to describe, which is a mobile integrated healthcare practice, it does very well in all three of these domains, we believe. What we want from around the table is how do we flesh this out in a accurate manner. So tomorrow's reality, we hope, outcomes will matter more than process. And we think we're already headed in that direction. Performance measures will be evidence-based and drive reimbursement. We think that's happening at the hospitals today. We can argue about some of those measures and whether they are truly evidence-based, but they're certainly more evidence-based than they were 5 years ago. And what the conversation we want to have, I think, is that these performance measures will be similar for EMS in the future than they are to the hospital today. And we're at an opportune time to be able to define what those measures are ourselves rather than have them defined externally for us. And we know those measures, or we believe it's CMS language, they understand it, and there's no reason to believe they can't apply it to the pre-hospital environment. We will be transparent, and at the moment we are expensive. If you look at how much it costs to run an EMS system versus the value proposition, we need to be in that. We need to be able to describe our value in a more eloquent way than what we do today. which is where they're fast. And that's probably not going to be sufficient going forward to get all of this paid for. If you haven't seen this in your community, we certainly have seen it in ours. The hospital has a markedly renewed interest in EMS, our hospital destination guide, how quickly we can activate the STEMI program, and to assure that their patients return to them, and so forth and so on. I've had more conversations with hospitals in the past 8 months than I probably did in the previous 2 or 3 years about how can you help us in the new healthcare environment. So I think the opportunity is there, and most other communities around the table, I think, have seen the same. Lots of folks are moving their emphasis outside the hospital. We already have an emphasis outside the hospital. That's our job. That's where we are. So the other thought from the original meeting relied on the notion that our infrastructure is in place. So the incremental cost of doing anything that we're going to describe is on the margin, is much easier than recreating an infrastructure for what we're talking about. We've got the same leadership structure, and so tomorrow's reality is that we believe that EMS is the key component of this, but it is not the only component. And I think that's the other part that we realized very quickly, is that we used a lot of terms, and we decided to get away from terms that were in existence. So community paramedicine, advanced practice paramedicine, all of those terms describe a discrete program in a discrete community. And each community will have a different needs assessment. So rather than trying to co-opt and say, well, we're really talking about community paramedicine, or we're really talking about advanced practice paramedicine, or what have you, the notion is each community needs a mobile integrated healthcare practice. That we are not operating in a silo on the emergency side on 911 outside of all of the other healthcare reform and all of the other care plans in the community. So we think it's right care, right place, right time, meets the triple aim, because we are going to allow that patient to navigate through the healthcare system rather than just go reflexively to the hospital and have no prevention and no in-home care and all the rest from us. So these are the focused areas of practice that just came up, and this list is by no means exhaustive and will probably lead to a great amount of our discussion later today. But post-acute care, long-term chronic care, and post-ED care is separate than post-acute care from our discussion. So post-acute care is the standard stuff. Readmission, prevention, the language of the current healthcare reform. Post-ED care, an example, is the patient that is taking an oral diabetic med, they're hypoglycemic, they need to stay for observation in the ED for a recheck of the blood glucose every 3 to 4 hours. Send them home, have somebody from the mobile integrated healthcare practice, it may be a medic, it may be a nurse, it may be whoever, go by that home and do the blood glucose check in the home. Let them out of the ED. Frequent system users, and we try to stay away from the phrase abusers. These patients come through the system often because they are receiving bad care, and we need to improve their care. Their care is not coordinated. And if you take that 20 or 30 people in every million-sized community, which is about the right number, and you go through and monitor them, many of them have underlying substance abuse, underlying mental health disorder, and they are being treated for both episodically in an emergency department. And I don't know about you, but episodic visits to emergency department create psychiatric disorders and substance abuse, right? I mean, that does not solve the problem, that increases the problem. So we're giving them bad care, and we need to coordinate that care. Homebound and impaired mobility, and this is where we come into the preparedness piece as well. Knowing where these people are in the community, knowing who's on the ventilator, knowing who is going to need something when the power goes out or the snowstorm comes. In Raleigh, we would not be having this meeting, by the way. They said we would be closed. How do we go and take care of those folks, both on a day-to-day basis, but also in the preparedness realm of disaster? And then finally, health screening and public health things such as vaccinations, falls risks, all of those type of things. So those were kind of the areas of practice that came up, and clearly, I'm just looking around the room, you can see everybody here is already nodding their head on the other thing that's not on this list. And so we know there's things to add. It's not meant to be exhaustive. We cannot get away with it not ever talking about the money. The issue here for all of us is not that we want to altruistically do these things. Many of us that are in the EMS business have always added a service because it was the right thing to do for the community. We've done that a lot. You know, tactical EMS, for example. I don't get no reimbursement, but it's the right thing to do to have a medic with all our tactical teams. So we put that out there. That's a upfront cost. This program, though, is a double whammy, and we just need to acknowledge that. The more this program succeeds, the less revenue you receive. So you go actually backwards. It's not a break-even proposition. It is we add an expense and we subtract a revenue in the current model today. So we just need to acknowledge that. It still may be the right thing to do, and we've got to figure out how to do it, but that is the issue that we are confronting right now, and one of the reasons that we are here trying to get some insight is how can we make this sustainable when we are in the overall, we believe we're saving healthcare dollars, but us directly, we're going backwards. So a mobile integrated healthcare practice is where we hope to go, and Dr. Beck can describe that far more eloquently than I, so I'm going to hand that over.